Good afternoon on an icy afternoon in St. Louis. Welcome to Open Classroom. I'm Janet Gilla, Director of Professional Development for the Brown School here at Washington University in St. Louis. And whoever you are and wherever you're coming to us from, we welcome you. We are so happy to have you with us as part of today's program. For those of you that are joining us here on the Zoom webinar, chat is enabled, and many of you have already said hello, so we're grateful for that. That chat is also going to let you add your questions and comments as the conversation goes. And today I'm joined by my co-host Sarah Birch. This is a showcase, curriculum showcase event for us, and I'd like to invite Sarah to say just a few words, particularly of welcome to our prospective students before we get started.
Thank you, Janet, and thank you everyone for joining. My name is Sarah Birch. I use she, her pronouns, and I am an associate director for the Office of Admissions and Recruitment at the Brown School. And so on behalf of the Office of Admissions, welcome specifically to our prospective students who have joined. We're really glad to bring this new series to you all this semester, where we're showcasing the fantastic work of our colleagues across the Brown School, and to give you a sense of what it's like to be in the classroom with a faculty member. And so if you have any questions, of course, I know we have a deadline coming up for us. If you have questions about admissions, of course, but we hope that you join us for more open classroom sessions that are coming up. Particularly want to call attention to Monday's session on February 28th, where we'll be talking about community and policy practice during a pandemic. And March 1st, we'll be joined by Sharita Butler-Barnes for a talk entitled Raising Queens, the Important Role of Racial Socialization in the Lives of Black Girls, which will kind of mark the end of our celebration of Black History Month. So thank you all again, and I'll turn it back to Janet to introduce today's speaker.
Sarah. So Alexis Duncan is Associate Professor of Public Health here at the Brown School. Her research focuses on risk mechanisms and psychiatric comorbidity of obesity, eating disorders, and substance use disorders, particularly among women. Dr. Duncan is chair of our mental and behavioral health concentration within the MPH degree. So she's here today to talk to us and help us better understand eating disorders, sharing insights from epidemiology. Please welcome Alexis Duncan.
Thank you, Janet. I'm going to share my screen. Hello, everyone, and thank you for coming today. So as Janet said, I'm the chairperson for our specialization in mental and behavioral health for the MPH program. And this is one of the few such specializations in the country. And we are looking at mental and behavioral health from a public health lens and applying public health tools to improve mental health and well-being. And so we're looking at mental health more from the population than the individual level. So this talk today is going to be more of a population level talk. In our specialization, we have, so this talk is a version, I'd say it's version 3.0 of a guest lecture that I give in the first course of the sequence we have for our specialization, which is called Fundamentals of Mental Health for Public Health. And usually when I teach, I don't usually lecture for long periods of time. I often will have students do more of like a flipped classroom where the didactic portion of the course happens outside of class, and inside we just have discussion. So just wanted to put that out there. I will try and involve you at various points during this talk. And one of those times is right now. So let's take a little pretest to see what you all know about eating disorders. So here's our first question. Eating disorders are most common among people in which of these BMI categories? And what do I need to do to get this to happen? Anything? There we go.
We'll give people just a bit more time. About half of everybody has responded. You do need to scroll down because we have 4 questions lumped all together.
Yes. Okay. Lumped all together. Okay. Oh, and we're answering them all at the same time. Okay.
Yeah, exactly. Give folks just like 15 more seconds to reply.
I'm not actually going to tell you the answers to these questions right now. You will find out the answers during my talk. Okay. I'm going to stop sharing now. Oh, now I'm going to share the results so you all can see what you all think. Okay, so the largest plurality of you think that the most common BMI category or the eating disorders are most common among people in the normal weight category, that eating disorder rates are highest among white people, that about 20% of people with eating disorders are male, and that over 50% of people who have eating disorders are adolescents. Okay. So the first thing I would like to do is just make sure we're on the same page with eating disorders. I know many of you already know all about this, but for those of you who don't, eating disorders and other psychiatric disorders are defined by the DSM, the Diagnostic and Statistical Manual of Mental Disorders. And we're on the 5th revision here. And this is published by the American Psychiatric Association. So the, say, oldest or eating disorder, the eating disorder that was first defined, this was in the first DSM, is anorexia nervosa. And that's characterized by low body weight, fear of gaining weight or being fat, weight shape disturbance or undue influence of weight or shape on self-evaluation. So feeling like your weight or shape is the most important thing about yourself. And lack of recognition of the seriousness of low body weight may also be seen in people with anorexia nervosa. And there are 2 types of anorexia nervosa. There's the restricting type, which is where we would eat, restrict the calories, also sometimes what people are eating. I mean, like I knew someone who only ate peas and rice. And so the restricting type, and then binge eating, purging type, where I will talk about binge eating and purging in a minute. So
Alexis, are we supposed to be seeing your slides at this point?
you are supposed to be seeing my slides.
And we're not. I'm sorry to interrupt you.
That's really important. Okay. Let's see, share screen. That's the wrong screen. Okay. There we go. So you
There
didn't
we go. Perfect.
get results either. Okay. So here is, I was just going through the bullet points and showing Karen Carpenter, who, depending on how old you are, you may or may not know who she is, but she was a singer, who died from anorexia. 5 years ago. 5 years ago. course, there are lots of examples from current celebrities also, like Mary Kate Olsen. And binge eating, bulimia nervosa. And here I have a picture of, why am I blanking on her name? A famous person who has become public about having bulimia nervosa in the past. And that's characterized by binge eating, which is not just eating a whole lot at a sitting, but also feeling like you can't stop eating. So loss of control. And then these binges are followed by what are known as inappropriate compensatory behaviors to make up for the large amount of calories consumed during the binge. And so this may take the form of either purging, which would include vomiting and laxative use. Lady Gaga, see, I remember her name finally, described how her purging affected her voice from excessive or rather frequent vomiting. And then there are non-purging inappropriate compensatory behaviors. And that would include things like excessive exercise, fasting. And then another part of bulimia nervosa is excessive concern about shape and weight. The third of the big, we think of as the big three eating disorders is binge eating disorder. And this is Al Roker, who is someone who is famous for, he wrote a book talking about his binge eating disorder. And then he lost a lot of weight. So binge eating disorder is characterized by, again, overeating with loss of control, binge eating, and 3 or more of the symptoms I have listed here, and marked distress regarding binge eating. And I should add that bulimia nervosa and binge eating disorder, that there is also, it needs to occur at least once a week on average for 3 months or more. And bulimia nervosa first appeared, I believe, in DSM-3, which was in the 80s, and maybe 1980, if I recall correctly. Binge eating disorder was added in the most recent revision of the DSM, which came out in 2013. Also, just want to acknowledge that there are other feeding and eating disorders included in the DSM that I'm not talking about today. And last, but certainly not least, we have other specified feeding and eating disorders. And this is a category for people who have clinically significant disordered eating, and who, so that means that it's affecting their life roles, like their ability to work and be a student and have relationships with people, and or that it's to the point where they are seeking help. And so, but these people in this category, they don't meet all the criteria for an eating disorder. And one example here is atypical anorexia, where a person meets all the criteria for anorexia, but they are not underweight. Another one to highlight here is purging disorder, which is when a person engages in purging behaviors, but does not engage in binge eating. Okay. So in terms of the course of eating disorders, I'm going to point out here that the median age onset for an eating disorder tends to be, and most studies show that it is in adolescence or young adulthood. And so median means that 50% of people report onset prior to this, and 50% at later ages. And so this is pretty consistent with population-based studies, although even though this data came from a long time ago, even more recent data does show similar ages, although the age of onset for anorexia does seem to be creeping down. And then another important thing to note is the duration. So people with eating disorders, particularly bulimia nervosa and binge eating disorder, they have this for a fairly long time. So about 30% of people have multiple episodes, and the majority though do recover long-term, but many people on their way to recovery will cross over to different diagnoses. So they may start out with anorexia nervosa and then gain weight, but still be binging and purging. And so cross over to bulimia nervosa or gain weight and go into the more atypical, that would be what we now OSFED, the other specified feeding and eating disorders, and do that before recovering. It's also important to note that anorexia nervosa has the second highest mortality rate of any psychiatric disorder. Now, by comorbidity means having another health problem at the same time. So comorbidity is super common in people with eating disorders. And this is just a few of the physical health problems that are associated with eating disorders. And point out here that in addition to affecting your vocal cords from vomiting a lot, vomiting can erode tooth enamel. And so that's what this is showing here. And there is a push toward educating dentists to screen for eating disorders. And refer patients for treatment. Now, in addition, most people with eating disorders do have other psychiatric diagnoses, and having a psychiatric diagnosis is actually a risk factor for developing an eating disorder. So the data here come from a population-wide survey. And here we can see that the majority of people, particularly those with bulimia nervosa and binge eating disorder, have met criteria for another psychiatric disorder in their lifetime. And the most common being anxiety disorders or mood disorders. Now, the more diagnoses a person has, the more likely it is that they'll seek treatment. So it's not surprising that in inpatients, like in this example here, that almost all the people in this study of psychiatric inpatients have some other psychiatric disorder. Now, speaking of treatment, most people with eating disorders don't get eating disorder specific treatment. People with eating disorders are high users of health services in general, and the majority do receive treatment for, some mental health problem, but not eating disorder specific treatment. When they do receive treatment, it could be anything from inpatient, where you go and stay at a residential treatment facility, to outpatient treatment, where you see a therapist once a week. And the form of treatment or intensity of treatment also will depend on the age, diagnosis, whether or not someone has the resources to fund the treatment. And there's relatively sparse evidence. And it's not to say that the evidence shows that treatment doesn't work, more that there isn't as much research on eating disorders compared to other psychiatric disorders. And eating disorders are the most underfunded psychiatric disorder. So the research dollars per affected individual are the lowest for eating disorders. And I believe it's highest for autism. So eating disorders, some people are more likely to get eating disorders than other people. So what are the risk factors and what may cause eating disorders? Well, like with all other complex traits, it is a complex also interactions between genetic and environmental factors. So some risk factors, and this is again not an exhaustive list, gender and sexual identity. So women are more likely to get eating disorders than men. There's evidence also that gender and sexual minority people are more likely to have eating disorders. There's a genetic predisposition, not only having another relative who had an eating disorder, but there's also increased risk if you have a close relative with other psychiatric disorders. As I mentioned before, having a previous diagnosis since most eating disorders do develop by young adulthood, so previous diagnosis in childhood or adolescence. Childhood adversities, such as child abuse, peer difficulties, so bullying, trauma, dieting and weight control are a big risk factor. So eating disorders often start out with people trying to control their weight or lose weight. And over concern with weight or body mass index. And then there are lots of personality traits that are associated with eating disorders, the biggest one being perfectionism. Okay, so now we know about the what eating disorders are, the natural history, the risk factors. Now we can think about the burden. So by burden, I mean, well, how many people, what percentage of the population has eating disorders, and what's the cost? These data come from two studies, again, population representative studies, and showing the prevalence of eating disorders over the lifetime for adults, and then in the past 12 months for adults and adolescents. And then there are different bars for the different eating disorder diagnoses. And so these are not mutually exclusive, I don't think. So there may be people that have had both. And so you can see that over the lifetime, though, the most prevalent eating disorder is binge eating disorder. And with anorexia in this study being the least prevalent, although not all studies show anorexia as being the least prevalent. But there's reason to believe that this is an underestimate. And this more recent study that took used assumptions and data from a lot of clinical and epidemiologic studies to run a simulation model to estimate the true prevalence of eating disorders in the US found that about 14% of male people and almost 20% of females would experience an eating disorder by age 40. So that's not rare. A study that didn't use this simulation and estimation in Great Britain, they, looking just in women, found 15% of women met criteria for an eating disorder by midlife. And the 12-month prevalence was 3.6%. So that's kind of in the ballpark of this estimation in the US. Again, that's not rare. This is half of an infographic that was part showing the results from this report here, which was a combination of or came from a combination of, I'm drawing a blank again, of groups. So this strategic initiative for the prevention of eating disorders and the Academy for Eating Disorders partnered with Deloitte Access Economics to estimate the burden of eating disorders. So here we have the cost to the economy and to society, and it's a pretty significant cost. So these are all reasons why we should care about eating disorders at the population level. Now, let's take a break for a minute and do an image search for person with an eating disorder. So if you type into Google, person with an eating disorder, and then when you get the results page, you click on images up at the top. And what you should see is something like this. This is what I got a few days ago. So in the chat here, what do you notice about these images? So they're mostly women. They're mostly people who are thin and white. Exactly. It looks like they're portraying anorexia nervosa. So this would indicate to me that this is what people think about when they think of eating disorders. Younger also, yes. Now, a few years ago at a conference, a colleague of mine gave a talk, and she talked about how people think of people with eating disorder, that people with eating disorders are all skinny, rich white girls. And that doesn't make a good acronym, but I like the term. So I've borrowed this from her. We call this the myth of the skinny, rich white girl. So we think that, or the search results would indicate that we think that people who get eating disorders are skinny, rich white girls. And this has some important consequences that we'll talk about later. But let's pick this apart. So are people with eating disorders typically skinny? Well, actually, most people with eating disorders aren't skinny. And if we look at epidemiologic data, and this is from one study I did, but this is borne out in many other studies, we see that people with eating disorders are, yes, among women, people might be more likely to have had an eating disorder if they're underweight. But the highest prevalence is in people who have BMI in the obese range. And so if we add these two together, that would be the majority of people with eating disorders are in the overweight or obese category. Okay, so a lot of people with most people with eating disorders aren't skinny. Are they rich, or do they have a higher socioeconomic status? Well, overall, eating disorders are not associated with higher socioeconomic status. There are a few studies that show that anorexia nervosa may be, but overall eating disorders are not associated with higher socioeconomic status. Receiving treatment for an eating disorder, however, is associated with higher socioeconomic status. And just to show you a treatment facility. I mean, this is a particularly nice one. I'd like to go on vacation here. And they can be expensive. So you can imagine that going to a place like this is expensive for inpatient treatment. And of course, all people don't need inpatient treatment. And I will add that there are resources to help people afford treatment, but you need to have health insurance usually, or have an awful lot of money to afford treatment, even to afford being able to go once a week to a therapist if you have health insurance. Like my copay is $50. And so a lot of people don't have an extra $200 a month to go once a week. Okay. How about, are most people with eating disorders white, or is race ethnicity associated with having an eating disorder? Well, in general, white people are not more likely to have eating disorders than people of color. In fact, some studies show that some types of eating disorders and eating disorder behavior might even be more prevalent in people of color. There are some, so the answer is mixed, but it is clear that white people aren't the majority of people. Well, they might be the majority of people with eating disorders if they're the majority in the population from a mathematical point of view, but not overall more likely to have eating disorders. However, white people are more likely to think they need treatment, and they're more likely to be screened for eating disorders and more likely to get treatment. Okay, so the last part of this is girls. So are the majority of people with eating disorders girls? Is the typical person with an eating disorder a girl? And there's a lot of focus on this even in eating disorder research and treatment circles on girls, or rather girls, female persons under age 18. But the majority of people who have eating disorders are probably adults. And a lot of them aren't female. And so even though eating disorders may, now remember that if 50% of people, if the median onset is 18, then 50% may have onset before age 18. So they may be adolescents. But if you think about how long people have eating disorders, if the average length of time is several years, and that 30% of people have a recurrence of eating disorders, and putting all that together means that probably most people with eating disorders are over 18, so young adults, and not adolescents, which doesn't mean that we shouldn't screen in adolescents, because we'd like to stop it before someone gets to the point where they have a full-blown eating disorder. But it also means that we need to be screening in adults. So, and with regard to sex, that even though something like 90% of people with anorexia nervosa are male, that males comprise a much larger minority of people with other forms of eating disorders. And doing some back calculations from the results of that estimation paper I showed you, the estimation was something like 40% of people with eating disorders would be male. And also of note that sexual minority males are at much higher risk for eating disorders. However, like with these other things, that women with eating disorders are more likely to seek treatment. So where does the stereotype come from? Thoughts? If you have thoughts, put them in the chat. Media. Yes, so a lot of people are saying the media. An interesting thing that I found in looking for images of famous people with eating disorders, and I found all these lists of like celebrities with eating disorders, and they were all people who had anorexia nervosa and bulimia. Those people are showing up in the media as having eating disorders. And I couldn't really find much about people with binge eating disorder. So BMI is part of the diagnostic criteria, okay, for anorexia nervosa. So I'd like to, and sometimes medical health providers, TikTok, okay, lots of great things here. I would like to propose that it's also related to who gets treatment. Because as I mentioned, people who receive treatment are more likely to be lower weight. And that's partially a function also of, well, if you see someone who's lower weight, then people are concerned. So it might be more obvious they have an eating disorder, and the insurance company, especially for inpatient treatment, might be more inclined to pay for someone whose health is at more serious risk. We discussed that people who receive treatment are more likely to be affluent. It's really expensive. I saw someone in the chat say $1,000 a day for inpatient treatment. People who are white are more likely to receive treatment. Younger people, female people. So as you might notice here is skinny rich white girls are more likely to be in treatment settings. And incidentally, there's a lot of the eating disorders research is done on people in treatment. So what are the consequences here? So what I've shown is that people who have eating disorders, people who are treated for eating disorders aren't representative of eating disorders the way they present in the general population. And so this leads to a biased view of people with eating disorders, and this combined with what we're seeing in the media. And that leads to, well, part of it can go, the arrow could go both ways for that. The media depictions being biased, public perception biased, clinician training is affected. And it affects the diagnostic criteria. So that people in treatment, like what clinicians see in treatment, does affect the diagnostic criteria. Originally, I mean, we're moving towards including epidemiology much, much more. Originally, the criteria were developed by psychiatrists and saying this is what they saw in their clinics. And so these things all result in under recognition of people with eating disorders. And so people who don't fit the stereotype, they may not be screened. People, their loved ones may not be concerned about their eating. They may think, well, you know, people like me don't get eating disorders. And the consequences for public health are also pretty important, because all of this under recognition, and this is not just clinically, but they're also because if the criteria are biased towards what we see, for example, in women, but not in men. So men may not be concerned about being thin. They may be concerned about being muscular. But the criteria don't reflect that. And so then when we do surveillance, then we may underestimate eating disorders. And that gives this idea that eating disorders are rare when they're not necessarily rare. And because they're rare, then the government says, well, I don't want to devote the interview questions to surveillance of eating disorders, which is what's happened. It also leads to lower research funding. As I said, the eating disorders research is underfunded. And this under recognition of affected individuals goes back to people with eating disorders aren't represented. Treated for eating disorders aren't representative because the under recognition is not random. It is associated with gender, race, socioeconomic status, and weight. So all of this feeds back. And so now I'm calling on you, and it's really appropriate today to, or this week, because this week is Eating Disorders Awareness Week. I'm not sure, as you may or may not know. And so part of eating disorders awareness, or big part to me, is being aware of the people who don't meet the stereotype. And so we want to interrupt that feedback loop so that everyone gets the help they need. And these are just a few organizations that will have information about eating disorders if you'd like more information. This organization here, the Eating Disorders Coalition, does advocacy. So if you're interested in advocacy, that's a good one to go to. And there are lots of advocacy opportunities through them. So that's all I have for you lecture-wise. And I want to take the rest of the time to chat with you.
Thank you so much, Alexis. For those of you who are watching with us live, please do feel free to put your questions in the chat and we will pose them to Alexis. But I will start us off with a question, and that is, and it may be too soon to tell, but just curious if there's been any emerging data about the pandemic having an impact on the prevalence of eating disorders.
Yes. It seems like eating disorder, and I'm not, I mean, I have to, for full disclosure here, I'm not that up on the literature, but it is my understanding that there has been an increase in eating disorders. Yes.
Seth,
about that.
Yeah, Seth was wondering whether you are okay with us publishing the slides from this presentation. Is that something we're going to be able to do, or is that something you want to think about?
Sure. Yes.
Great. Okay, I will throw a link in the chat in just a second to share the website where they will be. They're not there yet, but give us a minute, and if you want the slides, we have a central place to store them. Alexis, I'm wondering if you could comment on if public health interventions are often, sort of population level, not intervention level. What does population level prevention look like? And I'm also curious, based on the demographics of when people are getting diagnosed, like, is there an age or a circumstance that you think might be sort of pivotal to get to people and share information or support?
Good questions. So what does population level prevention look like? So when we think about primary prevention, which happens before people develop the health problem. And so in thinking about about the risk factors. So bullying is a risk factor. Anti-bullying campaigns are prevention for, all sorts of things. Reducing stigma. Reducing weight-based stigma is very, very important. So I don't know how we do this, but as a society to focus less on how much people weigh is very challenging. But I think that and we are seeing some movement there. Let's see. So, I mean, those I think are two of the biggest ones. Of course, you know, childhood adversities is another one that we, across the board, like trying to reduce adverse childhood experiences, not only would help with eating disorders as prevention for eating disorders, but prevention for all sorts of other psychiatric disorders and more. So then the second part of your question was, well, and then there's screening. And in terms of eating disorder, can you remind me the second part of your question?
I was just asking about age or context.
Oh,
Like
age.
if we're saying this is what prevention looks like at the population level, just thinking developmentally and wondering what your take on that was.
Yes. So, I mean, ideally, we'd like to stop it before it starts or stop the progression to a full-blown eating disorder. And that is done in childhood and adolescence. So things, again, not focusing on people's weight, not focusing on how people look would be really beneficial. And so in terms of starting young, and then, but remembering that adults have eating disorders. So that, like the American Academy of Pediatrics says that all adolescents should be screened for eating disorders, but there aren't similar recommendations for all young adults, for example, being screened. So that's also important, that it's not just children, but children are really important. And again, that's where it all starts. But when we think about prevention, we're not just thinking about primary prevention before something starts. We're also thinking about catching people at early stages where they're more treatable, and that's secondary prevention. And we're thinking about how to, say, reduce relapse in someone who's recovered from an eating disorder in tertiary prevention. And that's throughout the life course.
Thanks, Alexis. So we've got lots and lots of questions in the chat now. So thank you, everyone, for putting those in. I'm going to go to Jonesy's question, which was about the cultural underpinnings of not seeing men's eating habits as troubling. So, you know, comments like "he's a healthy eater," that sort of thing.
Mm-hmm.
There's a lot of conversation about that.
Okay, so that is, I mean, I guess there are two things about that. Because that makes me think of actually the other side of it is that also culturally that we're depending on one's cultural identity, that like eating a lot or being, you know, a healthy size is seen as a good thing. Now, remember though, that having a higher weight does not equal an eating disorder. You're more likely to have an eating disorder or to develop an eating disorder, but that doesn't mean you have an eating disorder. It doesn't necessarily mean that a person is not healthy. So I just want to put that out there. But what we see is that like higher weight is bad, and that any efforts to reduce one's weight are good. And so, and that's where you think of like atypical anorexia or high weight anorexia comes in, is that a lot of people who are originally have high weight and then they lose a lot of weight, and they may do it in a really unhealthy way, and their labs look really bad, like, and they have all the characteristics of an eating disorder, but they're not underweight. And then a lot of the people in their life, including doctors, may say or validate the weight loss, even though it was unhealthy. And the same with exercising a lot. And that tends to be something that men do more than women, or having a focus on muscularity and having less body fat.
Thank you for that. I am not surprised that we have a very engaged audience. Oh my goodness, we have so many more questions than we're going to be able to get to, because clearly this is an audience that cares passionately about the topic. Several people have amplified this in the chat, and I recognize that you are an epidemiologist, not a therapist, et cetera, but you do have expertise in this field. So I want to ask what you would care to share. If somebody is trying to, is a parent themselves, or trying to support a parent of a young person with an eating disorder, if the resources aren't there to go to the $1,000 a day facility, or the wait list is there, I mean, if it's either a question of duration or that type of inpatient treatment is going to elude this family, are there resources available that are free, low cost, or, sort of in a more on demand? Anything that you're aware of that's support or help, even if it's not the gold standard of what you wish for these families?
I'm not, I don't know. But that is an excellent question. You say, I know who to ask, but I don't know myself. And I want to say that I just can't, and that's such a difficult situation. And I will disclose that I have lived experience as a young person with an eating disorder and as a parent. So my heart goes out to, and that is how I got into doing this.
Thanks, Alexis, and thank you for sharing that too. I'm sure there are many who, and I've seen in the chat too, that many can relate. So there are a couple questions about, education for doctors and medical professionals around considering eating disorders as a diagnosis option during a screening process. One person mentioned, never heard of this as a screening in the African American community. So is this something that is not taken as seriously in the medical field, or something that just is not as prevalently incorporated into education for medical professionals?
Yes, and not just for medical professionals, but also in social work, for example. And there's not a ton of information, like empirical information, but one study, I can't remember the exact numbers, but it's a minority even of child psychiatry fellowship programs offer specific training in eating disorders. Washington University does, and also the MSW program does offer specific training, but we are pretty rare. And so there is, I'm blanking on the name of, but there was buried within this big piece of legislation is a paragraph about money for training and for training doctors and dentists and other healthcare providers. And so there has been somewhat of a push towards increasing that, but it is, there's a dire need.
So we have several people raising questions and posing comments related to, I would say, sort of like youth sports that have weigh-ins and sort of a weight or strength focus, and I'm going to paraphrase and say, and an indoctrination that folks may be concerned that their healthy young people are getting to focus on the scale, etc. Not anticipating that you have any magic wands to counteract what they're experiencing, but I'd love to ask you to comment, about that phenomenon of athleticism actually perpetuating something that can be harmful for the child, and what can be done to do it better, if you have thoughts.
This is not my area of expertise. I will say I know McCallum Place has a specific program for athletes with eating disorders. I don't know what to do. I mean, okay, so I do know that where you've got weight classes like wrestling and boxing and being a jockey, that's all associated with eating disorders. I don't know how they can get around that necessarily, other than, I guess, when you're thinking about well-being and resilience. And so the more tools we have in our personal toolkit to stay on even, I don't know what the right word is, but to be healthy, the better we'll be able to resist these things. And so another primary prevention tool is things like social emotional learning programs. And so teaching kids how to take care of themselves, how to regulate their emotions, how to communicate with people. All of that is really important.
Alexis, so I'm going to pose one final question for us as we near the end of our time together. Lindsay posed a really great question that I had too, so thank you, Lindsay. They shared, as someone who's involved in obesity research as well as eating disorder research, how do you think scholars and public health leaders can approach messaging around obesity without perpetuating harmful weight stigma?
Boy, that's a billion-dollar question. I was actually thinking about this. So right before this, I was teaching, and we were reviewing an article on ADHD and obesity, and discussing this issue. And I have to say, I don't have an answer, but it's something that I've been thinking about a lot. And I've been trying to use different terminology. But the question is, like, did the field settle on particular terminology? I guess the answer is I don't know. But I know that I'm not alone in thinking about it. And what I do always do is when I'm talking about obesity, and like when we did that article today, I've started out with, BMI is not a great measure of adiposity, and, going in, there's a lot of stigma. And so acknowledging all the limitations.
Alexis, thank you so much for spending this time with us. Our audience has obviously been so very engaged, so interested in the topic. Do you have any sort of final thought or comment that you want to leave us with as a final message for today?
Oh, I wish you would have prepared me for this.
Sorry.
I just wanted to say thank you all for being here, and please reach out to me if you have any questions, and Janet can put my email in the chat. And for those of you who are admitted students or are thinking about applying, I would love to hear from you too. So I guess that's all. And I hope everyone's safe out there with the icy roads here in
Well, thank you so much. This has been really informative. Even when we learn what we don't know, embracing that is important as well. Sarah, I want to thank you for being my co-host for this series. Always a pleasure. To our audience, appreciate you joining us and hope to see you again at another Open Classroom very soon. Please take care, everybody. Goodbye now.
Bye-bye.